طيب Gash, are you ready?
Yes.
Scenario: Mr. Wilson is a 71 years old man with a background of COPD for which he is taking steroids. He developed perforated viscus and acute renal failure with hypokalemia. Clinically, has severe abdominal tenderness and rigidity, abdominal distension. Additionally, he is
Mhm.
hypotensive and tachycardic. Blood test showed ABG showed metabolic acidosis with a high lactate and high negative base excess, hypokalemia, high creatinine, hemoglobin dropped 2 units. Imaging show ultrasound free intraperitoneal fluids and chest X-ray clear with no air under diaphragm.
Mhm.
You are SHO in University of Birmingham Foundation Trust working with Mr. Jack. Call the
Okay.
ITU registrar, Mr. Anderson, to seek advice and inquire about the availability of the ITU bed. Okay,
Okay.
you have 8 minutes and 40 seconds. Let me put the timer.
Hello.
Hello,
Good evening, Mister.
good evening, doctor.
I am Dr. Muhammad working with Mr. Jack in University of Birmingham, and I would like to speak to ITU registrar for a guidance on on recently admitted annual patient needing laboratory. Additionally, I would like to coordinate a post-operative ITU bed. May I confirm that I am speaking to the ITU registrar?
Yes, you can call me Anderson. Now, could you please summarize your case?
It's nice to talk to you, Mr. Anderson. I have Mr. Wilson, 71 years old patient with a COPD, acute renal failure, and perforated viscus. Clinically, he exhibits severe abdominal tenderness, distension, hypotension, and he on metabolic acidosis and high lactate. His blood showed hypokalemia and increased creatinine with a drop of hemoglobin 2 units. Drop in 2 units of hemoglobin. His imaging showed free intraperitoneal fluid. Ultrasound was clear. Also, he is on steroid for now.
Okay, your patient has COPD. Did you check his oxygen level?
No, but I will check when I am off the phone, and I will let you know.
Okay, and how will you give oxygen therapy?
Yes, I will give oxygen therapy through venturi mask or nasal cannula at 4 unit per minute, 4 liter per minute.
And how you will maintain the saturation of the pressure of the oxygen?
The saturation will be maintained between 88% to 92%.
Okay. Why this approach?
This approach because I fear that he have respiratory failure, so his respiration is demand on the hypoxic drive.
Okay. Will you repeat ABG after giving this oxygen?
Yes, definitely I will do.
And what are the medications your patient taking for COPD?
Yes, he is on a steroid. He's taking fluticasone. He's taking also albuterol and vilanterol.
Yeah, Vilinterol. Yes.
Mm.
As you are planning to do surgery and your patient, a known case of COPD, any plans regarding the steroids?
Yes, I will give the patient hydrocortisone IV at induction,
Can you tell me the
100 milligram.
dose? Yeah.
100
And
milligram.
was an ECG performed?
I am not sure. I will check when I'm off the phone. I will let you know.
And can you tell me if the ECG is available, what findings are expected?
Yeah, if it is available, we will find manifestation of hypokalemia and atrial fibrillation.
And what about the fluid balance? Any chart taken?
Unfortunately, there is no chart available, but I will check and I will let you know after I finish the form.
Okay. How will you monitor his response to fluids?
Yeah, I will start with give the patient IV fluid from 1 to 1.5 liter Hartmann, and I will monitor the response for vital sign. I will check heart rate, respiratory rate. Um, I will check also the level of mental states and
Okay.
capillary fit and urine.
Whether urinary catheter inserted or you will insert it?
I will definitely check after I finish the phone, and I will let you know. But I will insert the
So
catheter. Yes.
else would you contact beside me?
Yeah, I will call the anesthetist, and I will call my surgical consultant.
And what about the antibiotics? Did you administer any antibiotics?
Yeah, I will take a sample for culture and sensitivity, and I will consult with a microbiologist according to the trust protocol.
So do we need to give the patient more blood because his hemoglobin is going down, as you mentioned?
Yeah, I will make sure to make cross matching, blood grouping, and check the level of hemoglobin, and I will consult the hematologist uh, after that. Yes.
Uh-huh. Okay, you mentioned this patient may have hypokalemia and atrial fibrillation. Can you tell me how you will treat the atrial fibrillation?
Yes, we will first treat the underlying cause, and I will address the electrolyte disturbance with cardiologist.
What else besides the electrolyte adjustment?
I will manage the underlying cause and manage the hypokalemia.
Yes, besides this electrolyte adjustment, what else you will do for atrial fibrillation?
For atrial fibrillation, I will consult with the cardiologist, but I will give a beta blocker for
To control
for
the
uh,
heartbeat, okay, what else?
for the rate, and I will give amiodarone for the risk.
Resume, okay. Is
Yes,
ICU admission necessary?
yes, it is very
Why?
necessary because of the patient have COPD and renal failure.
What if only one ICU bed is available and an asthmatic patient arrives first? What you will do?
I will continue monitoring the patient in the recovery room, and then I will make sure to I will contact you when bed is available.
From what we discussed, is this surgery risky?
Yes, it is it's have many risks, and we need a bed, ITU bed, for optimization those risks.
Okay. Yeah, this is my last question, doctor.
Okay, Mr. Can we summarize our discussion, please?
Do you need me to summarize your discussion?
What you need, if you want me to summarize, or you need to summarize, no problem.
Okay, you can summarize your treatment or your management.
Okay, thank you. I will check the level of oxygen for the patient. I will monitor in the patient, and I will make sure to make cross matching and blood grouping. And I will definitely call you when bed is available. Thank you so much for your time. Mr.
Okay, thank you,
That is,
doctor.
thank you so much.
You can go to the next session. 3 seconds, 2 seconds, 1 second, time up. Ali, do you like to start with Muhammad Akasha?
Yes, Muhammad. Very good. Fantastic. I think, Muhammad, did you ask new questions?
Yes, only one questions, but it's already written in the atrial fibrillation treatment in the critical care.
All right.
Yes.
Muhammad
But also-
Akasha,
Also,
fantastic.
ask it as this station before.
Yeah.
Yes, it's gonna be asked.
Muhammad, very good, Muhammad Akasha. Fantastic performance. Compare this to the start. That's a very nice one. I couldn't
Thank
even
you.
find a lot of mistake, to be honest. I just want you to tell me again the hypoxic drive. Why do we require that the oxygen to be between 88 to 92, the saturations?
Because of respiratory failure,
Yeah.
and his respiration is demand on hypoxic drive.
Tell me more about the pathophysiology. Why we give them less oxygen? Why don't we want the saturation to be 97 or 98?
I will escape that question.
All right. Okay. So I just wanted to want everyone to make sure that they understand it. You and me are normal people. We don't have COPD. All right.
Mhm.
We breathe CO2 and we exhale O2.
We breathe O2 and exhale CO2.
We breathe in O2 and we exhale CO2. Our brain, the respiratory center, will sense the CO2.
Mhm.
So hypercapnia is the drive for us to respirate. All
Okay.
right?
Right.
If you have a patient who has COPD for years and years and years, the receptors the receptors that test the CO2, they will have CO2 running in their blood higher than you and me because of the COPD. So they are the phenomenon we call it tolerance. لما تشرب سكر كتير الطعم بيبقى لك مسيخ محتاج تزيد السكر. Do you understand? So the receptors will tolerate the CO2. The CO2 will be ineffective for them to breathe. So they depend on the hypoxia.
لازم تزيد CO2 عشان يتنفس. ايوه.
Okay.
They depend on the hypoxia. If you give them a lot of oxygen, you will block the hypoxia, so they will not respirate. Okay.
ناقص عشان كده. ايوه.
واضحة يا عكاشة؟
واضح.
لا واضح. لكن he will ask about this question
maybe.
يلا comment about other performance عادي.
I don't have any. You just said I will start with give instead of I will start with giving this and giving that. And you also said, on the phone call, you usually don't ask your examiner to summarize. You summarize.
Yes.
I didn't ask. I said let's summarize what we have. Then Muhammad, he said, you want to summarize or
yeah, but because you don't make it clear for me.
Wait, Muhammad. Then you said no problem. You summarize or I summarize.
Indian technique, yeah.
Akasha, you don't ask. Look, you don't give a chance. You immediately say, if you have time, okay, Mr. John. Now I'm just gonna summarize our discussion. I'm gonna do this. I'm gonna do that, and that's it. You do not give him the chance for him to summarize, Muhammad. Yes, but to be honest, I couldn't find a lot of mistakes. Very fluent, very to the point, very calm. Akasha, your improvement is fantastic.
Yes.
Thank you.
Very nice presentation, Akasha. I think Ali covered the point and you answered all the questions targetedly and clearly. The only things that you got confused when I asked you about the treatment of the atrial fibrillation. So expect that you may face a new questions and you manage it well. Also,
yes.
Otherwise, regarding the summarization, as Ali said, let me summarize. Okay, Mr. Anderson, let me summarize our plan of management. Otherwise, perfect, nice presentation.
Okay. Just I have one question.
Okay.
For the patient required transfer, can I ask the examiner at the end, like, did you accept the case? It will not be appropriate to ask.
He will say, okay, you can proceed with the referral. He will say that.
If he not say that,
you can ask him. Okay,
I can
Mr.
ask
Anderson.
him,
Yes, Mr. Anderson, are you willing to accept this referral?
are you willing to accept this? Okay,
Yeah.
okay. Thank you so much for your
Okay.
time.
Yes.
Mm.
Should we go to the next station? So the next station with Muhyi, acute limb
Yes.
ischemia. Yes. Are you ready?
Yeah.
A 70-year-old woman admitted with abdominal pain, initially diagnosed as acute diverticulitis, respond well to analgesia and antibiotics. She is complaining of severe right leg pain. Clinically, the pulse rate is irregular. Blood investigation showed right lower limb pale, pulseless, hypokalemia noted. ABG reveals metabolic acidosis. Other investigation, arterial duplex imaging confirm acute arterial blockage, and ECG shows atrial fibrillation. You are CT1 vascular surgery working with Mr. Lee. Call the vascular consultant to provide an update on the patient and request acceptance of the referral. Okay?
Okay.
So let me put the timer. You can start.
Hello, I'm Dr. Mohammed, a CT1 vascular surgery. I'm calling to speak with Mr. Who, sorry?
You can read from the file, doctor.
You have the file in front of you, doctor.
Can read it from the file.
Mr. Ali, the vascular consultant, to request accept for my patient. I'm going to refer it with who is having acute limb ischemia.
Yes,
Could I
can you
confirm?
I'm the vascular consultant on call. Can you please summarize your patient for me?
My patient is 17 years old woman with mild diverticulitis. She has acute presentation, which is painless and pulseless, loss of her pulse on her right lower limb, and investigation reveals that has metabolic acidosis and low potassium, and on her ECG there is atrial fibrillation, and arterial duplex ultrasound as well showing that it might be blocking on her one of her vascular on her right lower limb. So I suspected that acute limb ischemia. This is
why do you suspect acute limb ischemia?
Because the clinical sign of pallor and pulselessness and the pain and the investigation that shows the laboratory for her and the imaging.
What imaging? Remind me, please.
Duplex imaging result, duplex arterial duplex.
Okay.
And arterial fibrillation from ECG.
All right. Okay. Is it urgent?
It's urgent,
Why?
doctor, yes.
Why?
Because the patient has acute limb ischemia and there is susceptibility of losing his limb.
Okay, all right. Yeah, that makes sense. What is the earliest sign of ischemia, you know?
The pain, the severe pain on his.
Severe pain. Okay. And what is a positive 2-point discrimination test indicates?
Say again?
What is the
Sorry?
positive 2-point discrimination test indicate?
Pulse.
No.
And can you case the question and then we...
Okay, yeah. Can you tell me the 6 P's?
The pulselessness, البين بالر, and bielothermia أو boikilothermia, paresthesia, and paralysis.
All right. All right. And what is boikilothermia?
Coldness.
All right. Do you need a cardiologist to review premature ventricular complex before transfer? You said she has atrial fibrillation, and I can see from the ECG she has premature ventricular complex. Do you think a cardiology review would be appropriate?
So the top priority for me now to revascularize her right lower leg. So this is, we can do that later. The BVC, we can do it later. I'll do the assessment.
Okay. What's the suspected cause of her arrhythmia from the blood test you told me?
Hypokalemia.
Hypokalemia, okay. What do you think of her assumed diagnosis of diverticulitis? You mentioned she has diverticulitis, and now you know she has atrial fibrillation. What do you think about that? You have a better explanation?
The atrial fibrillation may be the reason behind the both issues, the atrial fibrillation and the acute abdomen. It might be even thrombus for the mesenteric.
All right. So you think of mesenteric ischemia instead of diverticulitis?
Yeah.
So you think she was misdiagnosed with diverticulitis? Is that correct?
It might be misdiagnosed, but we can confirm that later by doing another investigation.
Okay, fine. Is it possibility? Okay, so I just want to ask you: is it possible to be mesenteric ischemia?
Yes, might be mesenteric ischemia.
Okay. What you gonna do to just to confirm the mesenteric ischemia? What investigation will you do?
I will do a clinical examination to check
I want imaging.
a CT abdomen.
Okay. All right. Do you want to scan the abdomen first?
Our priority now for her
حبيبي عين علي.
ischemia.
I don't see her, Muhammad. You can let her in yourself. I don't see her. Yeah. Continue.
Okay.
Continue.
We need to treat her urgently for her right limb because ischemia, as you know, for if we leave her for a long time, she might lose her right lower limb, her leg. So we need to.
All right. I do agree. It's more priority.
And then we can run another investigation like do abdominal.
Fine. Okay. So can you remind me again what imaging you're gonna do for this lady?
CT abdomen.
No, I mean to diagnose acute limb ischemia. You just mentioned.
Arterial duplex ultrasound and CT angiogram.
All right. Okay. What will you do if the patient has contrast allergy and we can't do the CT angiogram?
A magnetic resonance angiogram.
Yeah. How to transfer her? If I said, yeah, bring her to my hospital now.
We'll do that urgently by calling the ambulance with a blue light.
Ambulance, okay. How will you prepare the ambulance?
I will make sure that she has a CBR set device and the
She has
serum.
what, sir? Sorry?
CBR set.
Okay.
A serum pump.
Yeah.
For cardiovascular resuscitation.
Fine. And what your management plan will be? Give me just general idea how you're going to deal with such a lady.
We'll treat her according to care of critical ill surgical patients with to correct the reason behind her limb ischemia, which might be the hypokalemia, by giving her calcium chloride up to the 40 milligram liter on saline, and then monitoring her atrial fibrillation or her cardiac issue by ECG, and correct and monitoring the calcium level to be normalized as.
All right. How will you tackle
Yeah,
the
Imam,
atrial
continue.
fibrillation? How will you tackle the atrial fibrillation?
After we address the underlying cause, can we can control the rate by giving her a beta blocker.
All right. And how will you? Okay, beta blocker. What else?
Amidrolone.
Why for?
To control the heart rate or the rhythm.
Beta blocker control the heart rate. What amiodarone does?
Amidrolone for.
And what anticoagulation you gonna give acutely?
Fractionated heparin, 75 unit per kilogram, and then I will continue her daily dose with 18 unit per kilogram, monitoring her ABTT, and then we can adjust later the lower low molecular weight heparin.
Okay. How would you inform the family about the patient condition and the need for urgent intervention?
I will tell them that she has experienced acute the blood supply for her right lower leg has suddenly stopped, so we need to revascularize and to give a blood supply for that region in her body. This is why we referred her, or we are going to refer her to do this procedure and she need a cardiovascular surgeon to do a vascular surgeon to do it.
Okay. I think that's all. Thank you. You can go to the next station.
Thank you.
All right. Okay. Very difficult. It's not easy.
It's not easy at all.
Not easy, Muhyiddin. You answered all the question. Your performance is good, but I think maybe because we did the session earlier than what you expected, you didn't memorize exactly what's written. There was some answers coming from your head, right?
Yeah, because
yes,
the time was so short.
Yes, the time was very strict. So I will encourage you to memorize more. There is also a very important question. So you said my patient is 17 years old. She's 70, not 17.
70, okay.
Yes. You said she's having, instead of she presented with, or she has, investigation revealed that she has. Look, there was a couple of grammatical mistakes while you're doing the presentation because you didn't memorize what's written in the school. And that because we have a very short time. We just advertised today for the session. So you need to memorize what's exactly written and say it exactly.
Okay.
You said one of her vascular artery. It's popliteal artery that's blocked. So you should be very specific instead of just one of her vascular. You said, can you, when I ask you a question that you didn't know,
should I
ask, yeah, Mahi?
Answer it just like that, or if is it in the file or no?
Yeah, they will tell you it's popliteal artery blocked in the file. When I asked you a question, you said, can you please skip this question? لكن هرتني. You said it in a maybe you don't look. You don't see it this way, but you said, can we please skip this question? You said it like in a very harsh tone. You don't want to do that. I'm the one who giving you marks. Be polite.
Really?
Yes. People at Muscan. Can we skip this question? Don't ever say it in a very rude way.
Okay.
Say it in a very nice, smooth way. Can we please skip this question? All right? Don't appear overconfident on your exam. Sergio's scared overconfident people. You know that. Yes. Don't say it in a harsh way. In the treatment, you mentioned the hypokalemia. Yes, the hypokalemia led to the acute limb ischemia. But treating hypokalemia will not treat the acute limb ischemia. Treating hypokalemia will treat that atrial fibrillation. Treating of acute limb ischemia is totally different. Muhammad Sadiq.
Yes.
What is the treatment of acute limb ischemia?
Immediate revascularization. First
Revascularization.
طبعا you start يعني when patient came to ER and the symptom and sign suggest the acute limb ischemia, you have first to start with giving her 5,000 IV heparin. After that, arrange for intervention, surgical intervention.
And the intervention is either intra-arterial
embolectomy.
Intra-arterial thrombolysis or embolectomy. Yes. So the definitive management we're gonna add now. So the hypokalemia treatment is just treating the atrial fibrillation. But if you want to treat the clot, you either do intra-arterial thrombolysis by giving TPA, tissue plasminogen activating factor, or you treat with embolectomy. You go inside the artery with the femoral or whatever, and you go with the catheter, you go with the cylinder, you reach the clot, you pass the clot, you inflate your balloon, and you bring the clot. Do you understand?
Back out.
So imagine this is a clot. You go inside from the femoral or whatever, and you go this way. You inflate a balloon or a specific device, and you take the clot out. We call this embolectomy. Each one has a specific criteria for it. For example, all patient you don't do, or you can go inside with a catheter, but instead of embolectomy, you inject tissue plasminogen activating factor that will thrombolyze the clot. But this has a risk of intracranial hemorrhage. Usually, it's contraindicated in elderly people because their arteries are very fragile. They may rupture and they may die. So usually, embolectomy for old people and intra-arterial thrombolysis for young people. That's one of the criteria. But they have specific criteria for each one to choose. But if in your examination, the examiner asks you what's the definite treatment of acute limb ischemia, say intra-arterial thrombolysis or embolectomy. That's it. I'm adding this question now to the school.
Yeah.
But otherwise, I don't have any point. I think, Muhyiddin, you made a lot of mistake. Okay? You made a lot of mistake. But these mistakes because you didn't memorize what's written. Okay?
I'm a bit confused about the case because this is my first time to do a phone call conversation or consultation.
Yeah.
It's more than excellent.
This
is your first session, Muhyi.
Yeah.
Very nice performance, Muhyiddin. I think Ali covered all the points. The only thing I would like to add regarding when Ali asked you, could it be mesenteric ischemia? Whenever possible, to add a reason, add it. You should say yes, it could be the possibility of the mesenteric ischemia, but I need to do a serial abdominal examination and I will let you know. If it's possible, add reason to your answer. Okay? Otherwise, memorize the treatment exactly. Ali helped you and he mentioned anticoagulation. Can you mention the anticoagulation that you will provide to your patient? Memorize the old treatment of your patient.
Okay. What the question that I skipped?
Yes.
The question he asked me and I couldn't answer and I asked you to skip it. What was the question and what was the answer for it?
It was a very important question. If your patient has allergy. No, you answered the allergy question. What was it, Muhyiddin?
Positive two discrimination test.
Oh, okay. You know, Muhyiddin, if you touch your hand with your finger like this, you will know that's 2 points, right? if you touch a patient and he cannot tell if this 2 points or 1 point, that's a positive 2-point discrimination test.
If he what?
If he doesn't know, you touch him with there's 2 points. That's a positive 2-point discrimination test. He's not able to identify that you touched him with 2 points.
And that means there is a limb ischemia at that place.
Yes.
Available, yes.
Positive, yes.
So when you touch with your 2 hands and the patient doesn't tell you if he can differentiate between 1 or 2, that means the patient is in ischemia and it's more likely the leg could be unviable. By viable, we mean you can save it. Okay?
Should we go to the next session?
Akasha, I already added the question. Can you see it on the school? I added it already, so everyone should be able to see it.
The last
Yes,
session.
thank you, Dr. Ali, but I need to also add for this question.
Yeah.
After embolectomy, who also the examiner may ask what else. So we need to mention the surgical bypass and amputation also.
Okay, so so usually, and correct me if I'm wrong, Muhammad Sadiq, we do bypass for chronic limb ischemia, not for acute limb ischemia.
Yes, it is fatal mistake to say bypassing acute limb ischemia. Acute
Yes.
limb ischemia, like thrombus from the heart, blocked the artery in the limb acutely.
But I agree with you for the last point you mentioned, Muhammad Akasha. If the limb is not viable,
yes,
and is dead, then we amputate.
I am just asking to make sure about the question. Even I am not sure about it.
That's fine.
Surgical bypass is not correct.
No, a bypass is for chronic limb ischemia, not for acute limb ischemia.
So embolectomy and for non-viable, it will be amputation.
No. Intra-arterial thrombolysis, then embolectomy, and you should say that. You should say that, and you should say if the leg is non-salvageable, then amputation. I'm writing that now.
Okay, please write it clearly. Thank you so much.
Non-salvageable.
يا رب تجينا الاكيوت لمب اسكيميا دي يا فتح الرحمن.
Yes, because the examiner may ask for it. What else like this?
To be honest, if your examiner asks you this question and you answered what I said now, he will give you high marks.
He will be very happy.
Yes.
Okay, thank you.
Because it's the answer that I like, that means you really understand vascular. That's you really. I have lots and lots of experience in vascular. That's why. Muhammad Sadiq. قطعنا ياما نحن قطعنا ياما.
That's an amputation.
All right, let's do the next.
Last session with Umar, I think.
He is here or
Umar, are you ready? Yes.
والله يا جماعه اكون معاكم صريح، والله احنا نديكم في معلومات مش للMRCS بس، شغل مستوى عالي، شغل فخيم، شغل بيطلع دكاتره فاهمين بيعملوا في شنو.
فاخر والاخر. فاخر والاخر.
Let's move to the last one, Muhammad.
Umar, scenario. A 21-year-old man involved in RTA at 5 a.m. He experienced transient loss of consciousness. His GCS initially 15 and hemodynamically stable. Physical examination. Swollen right hand. Left upper abdomen abrasions. Open tibiofibular fracture on the left lower limb. Investigations. X-ray revealed fractures in the right hand and left tibia and fibula. Abdominal ultrasound showed a free intra-abdominal collection. Blood test within normal range. Interventions, you administer tetanus, anti-tetanus, antibiotics, and intravenous fluids. At 1 p.m., the left leg showed signs of acute limb ischemia. And there is absent distal pulses, paleness, and worsening pain. Okay. You have 8 minutes. You are surgical clinical fellow working with Mr. Jones in Royal Free, London. Call the trauma head and update him about your patient. Okay.
I will be his patient. Yes, let's start.
Let me put the timer. You can start.
Hello, I am Dr. Omar, one of the surgical clinical fellow working with Mr. John on Royal Free London. I'm calling regarding updating my new trauma case. Can I confirm my talk? I was speaking to head trauma, Mr.
Yeah. I'm Mr. Borto. Okay, can you summarize what's going on for me, please? Can you summarize your patient, please?
Yes. Okay. 21 years old male, presenting with RTA, road traffic accident. He experienced transit loss of consciousness. His GCS was 15. His vital sign is stable. Physical examination showed swelling on right hand and left upper abdomen region, an open tibiofibrillar fracture, open fracture on the left lower limb.
All right.
Imaging showed, ultrasound showed free fluid intra-abdomen.
Yeah. Yes.
At 1 p.m., he developed sign of acute limb ischemia. No distal pulse and worsening pain.
All right. All right. What is the urgent issue with this patient?
Acute limb ischemia.
Okay. And why the call made? Are you worried that he may lose his limb? Why did you call?
I'm calling because we need it for urgent intervention surgery.
Okay. Can you tell me what the possible causes for this pulselessness you said? Pulselessness.
Yes, the possible causes is injury to arterial injury or compartment syndrome or arterial kinking, arterial spasm.
All right. And what was an ultrasound? Why was an ultrasound requested for the abdomen?
To rule out splenic trauma or splenic rupture due to abdominal abrasion in the left upper abdomen.
All right. And what is the approach if there's free fluid in the abdomen? Let's say you did the ultrasound and there's free fluids.
I will follow the advanced trauma life support and emergency laparoscopy.
All right. From what you said, what do you think the missed investigations are?
Missed investigation is CT abdomen and duplex ultrasound.
All right. CT abdomen, you said.
Yes.
All right.
CT angiography. Sorry.
Sorry.
CT angiography. Sorry.
CT angiography. And what else?
And duplex ultrasound.
All right. What else?
Also, I consider to CT brain and CT abdomen and pelvic.
Yeah, to search for different injuries.
Yes.
Okay. Is the patient wearing a C color now?
I'm really sorry, Mister. I cannot be sure, but I will check and I will update you.
Fine. How to manage this patient? You said with ATLS, right?
Yes.
Fine. What else you gonna do? Specifically, whom? Like, can you tell me which consultants you need to call now beside me?
Yes, I will call for general surgery, plastic surgery, vascular surgery, and orthopedic surgery.
All right. And what will you do regarding the mobility of the patient?
Immobilize the patient and traction the fracture and cover it without washing.
Fine. And what needs to be done before sending the patient to the theater?
I will give him, I will start the IV fluid. I will give him an analgesia, an antibiotic, and tetanus.
You will give him tetanus?
Yes.
All right. Okay. Let's say he has a wound which is dirty and not clean. And what the approach for the wound management in this patient?
Clean.
Cleaning the wound.
Sorry, again?
How are you going to treat a dirty wound if he has a dirty wound, laceration in his hand or feet?
I will consider it for wound debridement within 24 hours in the theater room.
All right, okay. And can you tell me in details what the necessary bloods that you're going to request?
I will request for CBC, ABG, LFT, RFT.
Yeah. There's another two more important investigation.
ESR.
All right. What else? What is the most important investigation we should do before taking any patient to operation?
Cross-matching, blood grouping and cross-matching.
Okay. How to fix the fracture and why?
It's preferring its external fixation. This initial for initial stabilization.
All right. Who may need to contact before or during the operation? You already mentioned who's gonna help you with the management now. But if we took him to the theater, whom you need to contact to arrange for the operation?
The theater technician and the anesthetist.
Yeah.
Also, I may be needed for general surgery and plastic surgery.
All right. And you have a fracture. So you
orthopedic fracture, orthopedic surgery.
All right. Why are you involving plastic surgery?
Because may need it for grafting, for opening fracture and
right. And why are we involving general surgeons?
To rule out any intra-abdominal bleeding.
Yeah.
And to rule out and for compartment syndrome treatment.
Okay.
Tracheotomy, if there is any suspect or any compartment syndrome.
Okay. All right, good. You can proceed to the next station.
Okay, thank you, Mr. Obio.
You have 10 seconds.
All right, good عمر. لاحظتوا يا جماعة الملاحظات بتاعتي قلت شديد لأنه الناس ما شاء الله شغلها كويس. المحطة دي very complicated and there's lots and lots of questions. There's also a lot of questions we added that you may not see on your exam just to make sure that you train yourself to answer different type of questions. Umar, you said your performance firstly is very fantastic. And let me tell you, your performance now, you may think I didn't do good, but you did very nice. Okay? Who will measure your performance is the examiner, not you. Okay? You answered all the questions. You missed some of the information, but you didn't miss the most important information. You said RTA, and at the same time you said road traffic accident. You're speaking to a trauma.
I remember you said no need for you must say the whole sentences.
This
That's
is
why.
acceptable to say it.
It's very common, Umar.
Yeah, it's very common.
We say crisp, and we say first we don't say it to a patient, and we say you should say crisp, but ATLS and RTA, that's fine. RTA, everybody knows RTA. You saying it, that will not affect your mark. You said the possible causes are you said the possible causes is the possible causes are this and that. Yes. You said I pushed you so hard for you to say CT abdomen and CT head. Because you forgot.
I did it wrong time.
No.
Yeah.
I asked you twice. I asked you
Ali,
twice.
Ali.
This topic, I read it.
No. Your performance is fantastic. Yes, but we put it in a sentence, and usually you like we didn't put it in 1, 2, 3, 4. We put it in like lines. That's why some people may forget it. So, but you need to memorize what's written. All right, especially the CT head.
Nowadays, Ali, just in this before to forget it.
Yeah.
For the investigation nowadays, they can say a pan CT or trauma panel CT plus the specific duplex and CT angio. If you do it more simplified.
So from let me be clear. From when we have a trauma coming to A&E, we call it whole CT.
Whole CT or pan CT.
Or pan CT. Just say whole CT. I think we should update it, Muhammad, on school. We should say whole CT. Muhammad, if you can update it now. So whole CT or pan CT. Okay? And then the specific request. You forgot the CRB and you forgot the cross match. Instead of CRB, you said ESR.
The same, all right?
Oh, no.
CRB and ESR is both inflammatory marker, but each one indicates something.
Yes.
Look, CRB is a protein. No, wait. CRB is a protein provided by liver, by hepatocyte.
CRB is the same protein.
ESR is erythrocyte sedimentation rate.
It's more
No,
chronicity.
I mean it the action. The both is inflammatory marker. Just
The difference only, ESR is the chronicity of the illness, while the CRP is the acute phase.
Yeah.
It's different in trauma setting.
acute phase protein.
Yes. So CRB is very important, and you said also. I also pushed you a bit hard to say the debridement of the wound. You said we clean. لا تقصد في عدة يا عمر. شنو we clean? Not
No, that clean ما جاوبت المثل. I'm not. I did not answer.
No,
I asked you, is it clean or?
Yeah, you should say we will do debridement and do this and that. Not we'll just clean. But otherwise, I don't have other point.
Our time, Ali, we call this surgical toilet.
Yeah.
Fantastic performance, Umar. This is your first station. And just only thing regarding the summary, please mention the time of seeing the patient at 5 a.m. and then 1 p.m. Okay. Because it will help the patient to know this case is urgent or not. Yes. Okay.
I needed to write this from the file or from my.
So we said in the first session in this phone calls, everyone can write on a paper the main details to present your case to your examiner. So it's better to write the information in the preparation room and then summarize the case in the exam room.
I say it from my head that one.
Okay. Otherwise, memorize the answer exactly as written in the school, Umar, and as it is your first performance, very nice.
Muhammad, did you update whole body scan?
No, because I'm writing.
Yeah. Let's update the whole body scan. Did we finish? Okay, we finish the communication now.
Yes.
History and communication. Luckily, there is no new stations. To be honest. Muhammad, ممكن توقف الريكوردينج.